Hemoglobinopathies. So a hemoglobinopathy refers to a genetic disorder which are characterized by the inheritance of either an abnormal hemoglobin, as in sickle cell disease, or an insufficient production of hemoglobin chains, as in thalassemia. All right, so for a globin gene overview, there are 6 functional globin genes which are involved in hemoglobin synthesis. These genes are distributed on 2 different chromosomes. So chromosome 16 contains the alpha-like globin genes, which are genes alpha and zeta, and then chromosome 11 contains the beta-like globin genes, which are beta, gamma, delta, and epsilon. The significance of this is there is different combinations and mutations in these genes that can result in various hemoglobinopathies and thalassemias. So we need to make sure we understand the location and function of these genes to make sure we can help grasp the pathophysiology of the related disorder we're going to be talking about. This is a video, if you're in my class, you'll be able to watch about hemoglobin development. So genetic mutations for the incidence, over 1,200 structural hemoglobin variants have been identified worldwide. These variants contribute to a broad spectrum of hemoglobinopathies. We have different types of mutations. So we have a point mutation. This is actually the most common type. It involves the replacement of a single nucleotide in the DNA sequence, and it can lead to amino acid substitutions, which can alter the hemoglobin structure and function. And then we have deletion mutations. These involve the removal of one or more nucleotides from the gene, and this can cause frame shifts or loss of essential protein segments. For insertion mutations, this is the addition of one or more nucleotides into the gene sequence. This can disrupt the reading frame and protein synthesis. And then we have fusion mutations. These occur when 2 or more genes break at nucleotide positions, switch places, and anneal to the opposite gene. This can produce hybrid or abnormal globin chains. For the pathophysiology, by definition, phenotype refers to the way a disorder manifests clinically or how genetic mutations translate into observable symptoms. So we have factors that can affect hemoglobin function. So the type of amino acid that is substituted. So different amino acid changes can variably alter hemoglobin structure and function. Some substitutions cause minor changes, while others can cause major dysfunction. Location in the globin chain, so mutations in critical regions such as the heme binding sites or even the subunit interfaces will have a greater impact on hemoglobin stability and oxygen affinity. For the number of genes that are mutated, so the extent of clinical severity often will correlate with how many globin genes are affected. So either like if it's a single or if there's multiple genes. So nomenclature for normal hemoglobins, these are named using letters of the alphabet for easy identification. So for example, we have hemoglobin A, which is adult hemoglobin, and hemoglobin F, which is fetal hemoglobin. For abnormal hemoglobins, we'll have a common name, which is usually chosen by the discoverer. It will often reflect the geographic location where the hemoglobin variant was first identified. So an example of this would be hemoglobin G-Copenhagen. You can probably guess it was found in Copenhagen. But there's also a scientific name, which is more detailed and standardized, and this includes the variant globin chain that's affected, so beta or alpha. And then we'll also have the sequential number of the amino acid residue in the chain. It'll also have the helical position of the abnormal amino acid and the nature of the amino acid substitution, or the original amino acid that was replaced by another amino acid. So an example of a scientific name would be hemoglobin S is actually called beta-6 glutamic acid. That's replaced by valine at position 6 of the beta globin chain. For hemoglobin S, so we have sickle cell anemia. History of this, so the origin is uncertain, but we know it dates back to 1670 in Ghana, and it was based on historical records that were found. For their inheritance pattern, so sickle cell anemia results from inheriting a sickle or an S gene from one parent. The other gene inherited may be another sickle, which is a capital S gene, so they could be homozygous, so capital S, capital S. It could get another hemoglobin C or a C gene or a beta thalassemia gene. These combinations lead to various sickle cell disorders, so we can have sickle cell disease, sickle hemoglobin C disease, and sickle beta thalassemia. For the prevalence, this is the highest frequency is found in sub-Saharan Africa. They have approximately 250,000 babies that are born annually with sickle cell anemia, so about 0.74% of all births in that region. In North America, there's about 2,600 babies that are born annually with the disease. For the pathophysiology of sickle cell anemia, you're going to have oxygenated red blood cells, so they'll be normal, biconcave, and disc shape. And then you're going to have deoxygenated red blood cells, which are going to assume a sickle or crescent shape due to the polymerization of hemoglobin S. There are two types of sickled red blood cells. So there are reversible sickled red blood cells. These hemoglobin S red blood cells will change shape back and forth depending on oxygen tension. The sickling will occur when oxygen tension decreases, and these cells can return back to normal shape upon reoxygenation. Then there's also irreversible sickled red blood cells. These red blood cells remain sickled regardless of oxygen tension, so they are permanently deformed and they are prone to hemolysis. This sickling will lead to clinical complications, and this is due to impaired blood flow and hemolysis. For clinical features, the age of symptom onset is generally pretty early. It's around 6 months of age, and that is as the fetal hemoglobin levels start to decline. There are some clinically significant variants that are associated with significant diseases. So we have the hemoglobin SS, which are both capital, so that means they're homozygous sickle cell disease, hemoglobin S beta thalassemia, and severe hemoglobin S beta thalassemia as well. There are some more listed there, but you do not need to memorize those by any means. Then we have different types of crises. These are vaso-occlusive crises. These are painful for the patient, and these are most common, unfortunately. And these are caused by a blockage of the microvasculature by the sickled cells, which leads to an ischemic pain. Then we have splenic sequestration crisis. This is the sudden pooling of sickled red blood cells in the spleen, which cause a rapid enlargement and severe anemia. There's also chronic hemolytic crisis. This is the ongoing destruction of sickled red blood cells, which lead to anemia and jaundice. Then we have megaloblastic crisis, and this is due to the folate deficiency from an increase of red blood cell turnover. And we can also have aplastic crisis, which is often triggered by the parvovirus B19 infection, which can cause a halt in the red blood cell production. So hemoglobin S does have an incidence with malaria. So the malaria species involved is the Plasmodium falciparum, and that's the most common and severe malaria parasite. So the mechanism of protection, or what we think happens anyway, is that the malarial parasites are intracellular organisms that live inside red blood cells and utilize oxygen for their metabolism. The presence of parasites lowers the oxygen tension inside infected red blood cells. These low oxygen tensions induce sickling of the infected red blood cells, and that's due to the hemoglobin S polymerization. So sickled, infected red blood cells become damaged and rigid, which makes them prone to trapping in microvasculature of the spleen and other organs, and also phagocytosis by macrophages in the spleen and liver. This process then leads to selective destruction of infected red blood cells, which will decrease the number of malarial parasites that are circulating within the body and increases the time for the body to develop immunity to malaria. So in summary, the unique sickling and destruction of parasitized red blood cells provide a protective advantage against malaria in individuals with sickle cell trait or disease. This selective destruction likely occurs in low oxygen tension environments, rich in phagocytic cells such as the spleen or the liver. For laboratory diagnosis of hemoglobin S, so they will usually see normocytic and normochromic anemia, so they'll have normal size and hemoglobin content for your red blood cells, even though they do have anemia. For the blood smear, though, we're going to see the presence of sickled red blood cells where they're going to look crescent or sickle shaped. So if you look down at the pictures, you can see those, sickle shaped looking red blood cells. We may also see target cells, which look just like a target. You can see that in the picture below as well. We may also see nucleated red blood cells in Howell-Jolly bodies, and this is due to splenic dysfunction. We'll also see polychromasia, and that is indicative of reticulocytosis. So for the reticulocyte count, it's typically going to be elevated, and that's due to the compensatory Merrill response to the hemolysis that's occurring. For the red cell indices, we will see the MCV, which will usually be normal or slightly elevated, and the red cell distribution width, or the RDW, is going to be increased, which will reflect variability in the red blood cell size, and that is also due to hemolysis and reticulocytosis. For cell counts, we're going to see anemia, so we'll see that decreased hemoglobin and hematocrit. For white blood cell count, it may be elevated due to inflammation or maybe even infection. Platelet count is usually going to be normal or maybe a little elevated. If we do a bone marrow on these patients, we're going to see erythroid hyperplasia, which would reflect increased production of red blood cells in response to the ongoing hemolysis. For laboratory diagnosis, we would do a hemoglobin electrophoresis. This is a test to separate and identify different types of hemoglobin based on their electric charge. So this is used to detect hemoglobin S, hemoglobin A, hemoglobin F, and other variants as well. This is to help confirm the presence of sickle hemoglobin or that hemoglobin S. We could also do a high-performance liquid chromatography test. This separates hemoglobin variants based on their retention time in a chromatographic column. Quantitative method, it is precise in measuring the percentage of hemoglobin variants, and it is useful in detecting hemoglobin S, hemoglobin C, hemoglobin F, and even beta thalassemia. We can also do capillary electrophoresis. This is an automated technique that separates hemoglobin variants by charge and size in a capillary tube. It has high resolution and it is a rapid test. So this is useful for newborn screening and for confirmatory diagnosis. Another test we can do is isoelectric focusing, or an IEF. This separates hemoglobins according to their isoelectric points. This provides a high resolution separation, which is helpful for identifying rare variants. This is often used as a confirmatory or even as a research tool. For treatment of sickle cell, we're usually going to manage symptoms and prevent any complications if possible. We want to try to keep them hydrated, and we want to try to keep the pain under control during times of crises. We're also going to have regular monitoring and health maintenance as well. For some drugs, we can do some hydroxycarbonamide therapy, and this increases the production of fetal hemoglobin in the red blood cells. Fetal hemoglobin, or hemoglobin F, actually inhibits polymerization of hemoglobin S, which reduces the sickling. Decreases frequency of vaso-occlusive crises and acute chest syndrome. It improves the overall survival and quality of life for these patients. For infection prevention, patients are actually at high risk for infections, especially pneumococcal. So we're going to do immunizations for that to try to prevent it. You can also do prophylactic penicillin in young children, and it will require a prompt treatment of infections to help reduce morbidity in these patients. We can also treat with blood transfusions. This is used to treat severe anemia, acute chest syndrome, and stroke prevention. Regular transfusions may be indicated in some patients, and we would want to be able to monitor for iron overload and alloimmunization if they continue, to get a lot of these transfusions. Some patients can also undergo a bone marrow transplantation. This is the only curative treatment that is currently available. This is the best outcome in children with matched sibling donors, and this is only considered in severe cases or frequent complications. Median life expectancy, so for patients with sickle cell anemia with the homozygous S, their median life expectancy is now greater than 50 years old. So this is a significant improvement from around 14 years back in 1973 due to advances in science and care. For occupational limitations, these patients should avoid strenuous physical exertion, exposure to high altitudes, and extreme temperature variations. These conditions can precipitate sickling crises. For sickle cell disease in pregnancy, so managing pregnant patients with sickle cell disease is quite complex. It requires careful preconception counseling, intensive monitoring during prenatal, during delivery, and postpartum. The goal is really to minimize complications for both the mother and the fetus. Hemoglobin C, so the prevalence of hemoglobin C it's found in 17 to 28% of people in West African descent. It is present in 2 to 3% of African Americans. For clinical features, they're generally mild clinical manifestations, and they may present with mild splenomegaly, and mild hemolysis is often common in hemoglobin C. For laboratory diagnosis, we're going to see normochromic and normocytic anemia. For their blood smear evaluation, we're going to see some microcytosis and mild hypochromia. We're going to see a presence of target cells. We're going to see an increase in reticulocytes. We're also going to see nucleated red blood cells. We're also going to see a characteristic hexagonal crystal, which can be seen in red blood cells, and that is sometimes called hemoglobin C crystal. And you can kind of see it in the picture there down below. It's kind of those really dark, crunched up looking red blood cells. Hemoglobin electrophoresis or high performance liquid chromatography can be used to confirm diagnosis of hemoglobin C. Treatment, there's usually no treatment required. So that's because clinical symptoms can range from asymptomatic to presentations that are actually pretty similar to hemoglobin disease in some cases. So depending on what their symptoms are would guide what we would need to do for treatment. And as mentioned earlier, diagnosis is confirmed by hemoglobin electrophoresis or high performance liquid chromatography. So hemoglobin E, this is found in about 30% of people in Southeast Asia. It can reach up to 50% in border areas of Cambodia, Laos, and Thailand. For clinical features, we need to make sure that we can differentiate this from iron deficiency, beta thalassemia trait, and hemoglobin E beta thalassemia. There is some malaria protection with this, as with hemoglobin S. So Plasmodium falciparum actually multiplies more slowly in people that have hemoglobin capital E, or that homozygous hemoglobin E. The mutation may provide some protection against malaria. It usually present with a mild anemia and really no other symptoms. As far as laboratory features go, the laboratory diagnosis must be confirmed by hemoglobin electrophoresis or high-performance liquid chromatography. For treatment, there's usually no treatment required for an isolated hemoglobin E, but if they have hemoglobin E beta thalassemia, we're going to treat it similarly to the beta thalassemia major, which is where they have chronic transfusion therapy, iron chelation therapy, splenectomy if hypersplenism is starting to occur, and possibly even hydroxyurea for severe cases. Hemoglobin SC disease, this is the most common compound heterozygous hemoglobinopathy. This is found in approximately 25% of people in West Africa. The incidence in the United States, it's about 1 in 833 births per year. For clinical features, this is generally a mild form of sickle cell disease compared to the homozygous hemoglobin S. Patients, can experience growth and developmental delays as well. For laboratory features, for the blood smear, we're going to see the presence of the characteristic hemoglobin SC crystals, often seen as lots of times we'll compare them as the Washington Monument shaped crystals. They're just kind of like a column looking option. For hemoglobin electrophoresis, we're going to be able to confirm the presence of both hemoglobin S and hemoglobin C variants. For treatment, it's going to be similar to sickle cell disease, and we're going to do supportive care, hydroxyurea in some cases, prevention and management of complications, and then blood transfusions as needed.